In this video, as we continue our study of the neck, we are going to discuss the nerves of the neck. So our objectives in this video are to describe the course, anatomical relations, and branches of the vagus, accessory, and hypoglossal nerves. We also want to describe the location and branches of the superior, middle, and inferior cervical sympathetic ganglia. And then we'll describe the formation and location of the cervical plexus and name its branches. This might be one of your longer videos, but I hope it isn't. But if you need to, just take a break in between each learning objective. So let's get started. First off, we're going to talk about the vagus nerve or cranial nerve 10. We've already touched on the vagus nerve when we talked about the vagus nerve throughout the thorax, because the vagus nerve is going to travel pretty low. I have enlarged the picture that you have in your notes so that we can see the vagus nerve in the neck just a little bit better. Vagus nerve is cranial nerve 10, as you already know. And it is a mixed nerve. And if you remember what mixed nerve means, that means that it has both motor and sensory fibers. The vagus nerve is going to originate here at the medulla oblongata. So you see the medulla oblongata here. It's going to be, as it exits the foramen magnum, continuous with the spinal cord. Above it, we see the pons. And then here at the medulla oblongata, we'll see the vagus nerve. And it'll originate here and then exit out the jugular foramen along with the cranial nerve 9, the glossopharyngeal nerve, and cranial nerve 11, the accessory nerve. And in the neck, it's going to descend within the carotid sheath, and I know we've mentioned that already. First, at the top, and we're not seeing the arteries in this photo. You just need to, if you want to see that, refer back to our study earlier of the carotid sheath. But it's first going to be between the internal jugular vein and the internal carotid artery in the top part of the neck. And then more inferiorly, it'll be in between the internal jugular vein and common carotid artery. So we see the common carotid artery here. It would be in between. If we had the vein, it would be running right. The vagus nerve would be right in between it. But then up towards the top, you see the internal carotid, and that is going to be where we'll see the vagus nerve running in between the internal jugular vein. So the artery is the only thing that's going to change in that formation in that carotid sheath. The vagus nerve, we will see, have two sensory ganglia or swellings. So you see them up here. There's a superior ganglia and an inferior ganglion. And these are going to contain the sensory neurons, the cell bodies of the sensory neurons of the vagus nerve. So these act pretty similarly to the dorsal root spinal nerves, the dorsal root ganglia of the spinal nerves that contain the sensory cell bodies. These have the sensory cell bodies for the vagus nerve. So the superior ganglion is going to be smaller and lies on the vagus nerve within the jugular foramen. So you see it right in there. And then the inferior ganglion is going to be larger and lies on the vagus nerve, but just inferior to the jugular foramen. So let's talk about the branches. First, let's talk about the branches that we'll find within this jugular foramen. We'll see two. We'll see this meningeal branch. It's very small, so you may need to refer to your notes and look at the picture or the Netter's plate. The meningeal branch is going to travel back up through that jugular foramen into the posterior cranial fossa and supply the dura mater of that posterior cranial fossa. It's going to be a sensory branch. If you see, it's blue here in this photo. Blue is sensory. So this is a sensory branch. And then you'll see the auricular branch within this jugular foramen. And this is also a sensory branch, and it's going to contribute to supply the ear. It'll supply the auricle, the external acoustic meatus, and also the tympanic membrane. Now, if we move on into the neck, we are going to see a couple different or a few different branches. First off, we'll see the pharyngeal branch of the vagus nerve, which is right here. This is a decent sized branch that is going to have motor innervation to most of the the muscles of the pharynx and soft palate. You'll see this one pretty high in the neck, and it's going to also provide a little bit of sensory innervation to the lower pharynx. So the superior or the pharyngeal branch of the vagus nerve is going to have both sensory and motor innervations. Motor, it's going to supply most of the muscles of the pharynx and soft palate, and then sensory, it's going to supply sensory to the lower pharynx. Next up is the superior laryngeal nerve. So the superior laryngeal nerve we see right here. So it's branching just a little bit lower than that pharyngeal nerve. Now we have the laryngeal nerve. And it is going to divide into internal and external pharyngeal nerves. First, the internal pharyngeal nerve is going to be a sensory nerve, and you see it piercing the thyrohyoid membrane. It's going to do this alongside with the superior laryngeal vessels and supply the sensory innervation to the mucosa of the laryngopharynx, and then just I can get all the way down to the vocal folds in a small area on the posterior part of the tongue. So that's the internal laryngeal nerve. That will be sensory. The external laryngeal nerve we see is going to continue traveling inferiorly, and this is going to be a motor nerve. It will innervate the cricothyroid muscle and then also the inferior pharyngeal constrictor muscles. And those are going to be muscles we haven't quite talked about yet, but we'll be talking about them soon. The vagus nerve is also going to have cardiac branches that are going to be coming traveling to the heart and end in a plexus around the heart. And then also within the neck, you will see the right recurrent laryngeal nerve. And you see that right here. We'll only see this on the right side in the neck because the right recurrent laryngeal nerve is going to loop around the right subclavian artery. The left recurrent laryngeal nerve is going to loop around the arch of aorta. So that happens in the thorax, and we already talked about that branch of the vagus nerve. So again, the right will loop around the subclavian artery. That's the right recurrent laryngeal nerve, while the left will loop around the arch of the aorta. So next, let's talk about the accessory nerve. The accessory nerve, or cranial nerve 11, is going to be formed by the union of two roots. We will actually see the cranial nerve 11, or the cranial root of the accessory nerve. And then also we'll see the spinal root of the accessory nerve that's going to originate from C1 to C5 segments of the spinal cord, and then it'll send in the vertebral canal in between the ventral root and the dorsal root, make its way up and enter into the posterior cranial fossa through the foramen magnum, and then it will join with that cranial root of the accessory nerve and exit through that jugular foramen along with the vagus nerve and the hypoglossal nerve. And you will see that pretty soon after exiting the jugular foramen, the cranial root is going to split from the spinal root, and the cranial root will join the vagus nerve. The spinal root of the accessory nerve will then continue to travel inferiorly to supply sternocleidomastoid and trapezius. So remember, the accessory nerve will supply sternocleidomastoid and trapezius muscles. Sometimes you will hear these muscles talked about that they're innervated by the spinal accessory nerve, that's because it's coming from the spinal root of the accessory nerve, which the spinal root, if you remember, is originating from C1 to C5 spinal nerves and then traveling superiorly in the vertebral column in between the ventral and dorsal roots, and then making its way up to the posterior cranial fossa and entering via the foramen magnum. And then it will join with the cranial root of the accessory nerve, exit through the jugular foramen, where the cranial root will split from the spinal root and join the vagus nerve, and then the spinal root will continue inferiorly to supply trapezius and sternocleidomastoid. So if you think about what would happen with a lesion of the accessory nerve, then you can really think about it based on what muscles that it innervates. So it innervates the trapezius. So if you had a lesion of this muscle, you might see shoulder drop on the side of the lesion. Also, you might see difficulty with full abduction and elevation or shrugging of the shoulder, and then also difficulty rotating head to the opposite side of the lesion. So I'd leave that up to you. Since we know that it innervates both trapezius and sternocleidomastoid, why are these actions affected by the accessory nerve? So if you understand the actions of both of those muscles, then you understand why that you would see lesions of these motions. Next up, we're going to talk about the hypoglossal nerve. The hypoglossal nerve is cranial nerve 12. The hypoglossal nerve will contain, you know what, I think that I misspoke just a little bit, and so if I confused you, I want to go back and unconfuse you. In the accessory nerve, when it leaves the jugular foramen along with the vagus nerve, it also leaves with cranial nerve 9, the glossopharyngeal nerve, not the hypoglossal nerve. And I think I said hypoglossal nerve when I was talking about that, but it's the glossopharyngeal nerve when you exit that jugular foramen. So cranial nerves 9, 10, and 11 will exit that jugular foramen. But we are talking about the hypoglossal nerve now, which is cranial nerve 12. So let me get back to this photo. Cranial nerve 12 is the hypoglossal nerve, and it contains motor fibers that supply all muscles of the tongue except for the paladoglossus. The paladoglossus is going to be innervated by the vagus nerve, but all other ones are supplied by the hypoglossal nerve. That sounds like a good test question, doesn't it? All muscles are innervated by the hypoglossal nerve except, and then have a list of tongue muscles, and then the answer would be paladoglossus because it's innervated by the vagus nerve. Now, the hypoglossal nerve is going to originate from the medulla oblongata, but then it'll exit the skull via the hypoglossal canal. And then from there, you'll see it descend almost vertically. And then what will happen is that when it gets to about the level of the mandible, it'll curve around the occipital artery, and you see it happening right here, and then kind of change directions and turn towards the tongue. Okay, so it'll change direction as it loops around that occipital artery. As it enters into the oral cavity, it's going to pass deep to the mylohyoid muscle. So you see mylohyoid muscle here. There's the hypoglossal nerve traveling deep to that mylohyoid muscle. It's also going to travel over the lingual artery. Then also you'll see that it will travel lateral to the or superficial to the hypoglossal muscle. So you see that right here. So the the hypoglossal nerve is traveling deep to the mylohyoid muscle and then superficial or lateral to the hyoglossus muscle and that lingual artery. Now, when we get opposite of C1 or the atlas, then you will see that it is joined by fibers from the ventral ramus of C1 spinal nerve. And we've talked about that already, right? Those C1 fibers will supply the motor innervation to the infrahyoid muscles and geniohyoid, and then sensory innervation to the dura mater of the posterior cranial canal. So C1 kind of hitches a ride with the hypoglossal nerve. The only branches of the branches of the hypoglossal nerve, or the tree branches of the hypoglossal nerve, will only supply muscles of the tongue. So they'll innervate muscles of the tongue. The fibers that will appear like they're coming from hypoglossal nerve and are innervating those infrahyoid muscles, those are going to be fibers from C1. Now, when we talk about a lesion of the hypoglossal nerve, you will see that you will get paralysis of the tongue muscles on the side of the lesion. So if you have a patient stick their tongue out and the tongue deviates towards the left side, then the lesion is on the left. And you also could look at the tongue to see if you have muscle atrophy on that side. This is a common way that you can kind of see a difference between a lesion of the vagus nerve and a lesion of the hypoglossal nerve. In a lesion of the vagus nerve, if you have them stick their tongue out, the tongue will deviate to the opposite side. So if I had a lesion of the vagus nerve on the left side, then my tongue would deviate to the right side. But a lesion of the hypoglossal nerve, if I had a lesion on the left side, my tongue would deviate to the left side. All right, moving on. We are going to now talk about the cervical part of the sympathetic trunk. So this is just going to be an upward continuation of the thoracic sympathetic trunk. It's a continuous structure. We already did talk about the thoracic sympathetic trunk. You'll see that the sympathetic trunk is going to lie posterior to the carotid sheath and anterior to the prevertebral muscles. You can see a little bit better in this muscle. These structures here would be within that carotid sheath. And then here are the anterior cervical muscles. And then here's our sympathetic trunk. The sympathetic trunk in the cervical region receives no white communicating rami. So where do they get the preganglionic fibers then for the cervical sympathetic ganglia? Well, the preganglionic fibers for the sympathetic ganglia, the cervical sympathetic ganglia, are going to originate from the upper 4 thoracic segments of the spinal cord. So you see that right there. So the white communicating rami of T1 through T4 will ascend through the sympathetic trunk to reach the cervical ganglia. So you see it right here as that is traveling up from the thoracic region. It will continue to supply those cervical ganglia. Usually the sympathetic trunk will have 3 interconnected ganglia. You'll have the superior cervical sympathetic ganglia, the middle cervical sympathetic ganglia, and the inferior cervical sympathetic ganglia. These are all interconnected, as this sympathetic trunk is a long continuous trunk. Sometimes there'll be a 4th that will be present on the vertebral artery close to its origin, but not as often. Now, all branches that will originate from these ganglia will contain postganglionic sympathetic fibers. So remember, it's getting its preganglionic sympathetic fibers from the thoracic spine. Those white communicating rami are traveling up through the sympathetic trunk to supply those preganglionic sympathetic fibers. All the branches of these ganglion are going to be post-sympathetic or postganglionic sympathetic fibers. So the largest of the cervical ganglion is going to be the superior cervical ganglion. And you'll see this at about the level of C2, C3, or just higher up in that cervical spine. It will have branches that will go to the internal and external carotid artery, and you kind of see them there. It will also have the gray communicating rami to spinal nerves C1 through C4. And then it will have branches that go to the pharynx and down to the heart. The middle cervical ganglion is going to be the smallest ganglion and actually is going to be the most variable of the ganglion. It'll commonly be at the level of C6 and be pretty close to the inferior thyroid artery. You'll see branches. You'll see gray communicating rami to spinal nerve C5 and C6. And then you'll see branches that go to the thyroid and then branches that continue down to the heart. Now, the inferior cervical ganglion will commonly fuse with that first thoracic ganglion to form the cervicothoracic ganglion. But it still is its own ganglion that we're going to talk about. That's the inferior cervical ganglion. It lies anterior to the transverse process of C7 and neck of the first rib, and posterior to the origin of the vertebral artery. So we see that everything's been cut away. The vertebral artery has been cut away so that you can see the inferior cervical ganglion here. Now, its branches, you'll see gray communicating rami that go to C7 and C8. And then it'll have branches that go to the subclavian and vertebral arteries. And it will form a plexus, and you kind of see it happening here on that subclavian artery around these vessels and all their branches. And then it will also have branches that go down to the heart. Now, lastly, certainly not least, we're going to talk about the cervical plexus. We've already talked a little bit about the cervical plexus and detailed these nerves, so this is just be a quick recap about the cervical plexus. This is one of the less complex plexuses that we're going to study. In Gross 2, when we study the brachial plexus, and you've already studied that, you know that one is a lot more complicated. This one here is just a small looping plexus. So it is formed by the ventral ramus or rami of C1 to C4 spinal nerves. And these ventral rami are connected by these nerve loops. You're going to see the cutaneous branches, which we already did talk about. Remember, we had the lesser occipital nerve. We had the great auricular nerve. We had the transverse cervical nerve. So there's the great auricular nerve, transverse cervical nerve, and then you had the suprascapular nerves. Also, it will give us the ansa cervicalis. Remember, we talked about that, how it forms this loop. And then also a big branch is going to be the phrenic nerve. Remember, the phrenic nerve comes from C3, C4, C5. And if you think back to DAA, keep the diaphragm alive. The phrenic nerve, what you see here, is a branch of that cervical plexus. And then that phrenic nerve will descend anterior to the anterior scalene muscle, and then be crossed by the transverse cervical and suprascapular arteries, and then it will then pass anterior to the first part of the subclavian artery and then descend through the superior middle mediastinum, which we already talked about, to reach the diaphragm. And then the cervical plexus will have muscular branches that will supply the prevertebral muscles, scalenus medius, levator scapulae, trapezius, and sternocleidomastoid. Now, those innervations of trapezius and sternocleidomastoid are just going to be proprioceptive. If you remember, proprioceptive means where we are in space. The cervical plexus will contribute to that proprioception of those muscles. So now you should be able to describe the course, anatomical relations, and branches of the vagus, accessory, and hypoglossal nerves. You also should be able to describe the location and branches of the superior, middle, and inferior cervical sympathetic ganglia, and to describe the formation and location of the cervical plexus and name its branches.